Right, thanks very much, Lara. It was a wonderful dinner last night and very heartwarming. It's a wonderful group of people. I'm very honored to be here today. I'm going to talk about headaches, which is rather like opening Pandora's box, but we'll do our best. When I see someone with headaches, I think of all of these things and actually a lot more, and we're going to discuss them today. Start off with Chiari, and this is a typical Chiari malformation, and you can see the cerebellum here dipping through the base of the skull, the foramen magnum, and here's the syringomyelia. And so it's, okay. This is the Chiari malformation right here, dipping through the foramen magnum. And that is a classic Chiari malformation with a syringomyelia right here. And that is likely to cause headaches. But I see. Right, thank you. But chronic migraine headaches occur 3 times more commonly with Chiari malformation. They can be variable migraines, tension-type headaches, cough headaches. And so the presence of a Chiari doesn't necessarily confer a diagnosis of a Chiari headache. The Chiari headache is typically characterized by the fact that it's precipitated by a cough or a Valsalva maneuver. It may be protracted from hours to days, usually in the suboccipital region or the back of the head. And it's often associated with signs of cerebellar symptoms such as incoordination and nystagmus, or lower brainstem or spinal cord changes. Well, here's a patient for whom I had performed a Chiari decompression a number of years before. And I had decompressed the foramen magnum here, and now she came back with severe headaches and some memory changes and fatigue. So one could look at this and say this person really needs another decompression. But I obtained a CT scan, and you can see on the upper left there that the brain looks very tight. And I obtained a MRI, and if you look at the MRI in the lower left, you'll see this increased blood flow along the perivertebral venous plexus. And so I obtained an MRV of the brain, a venogram. And you can see that the blood flow through the sagittal sinus there with the arrow is not flowing. That's a blood clot, a thrombus. So she had a thrombosis of the sinus, the major draining vein from the brain. And if you look on the arrow there, the left transverse sinus shows no flow. So we treated her with Lovenox, and within a couple of weeks we had good flow through the sinuses, and she improved. Now this young lady had undergone a craniocervical decompression 1 year before, and she is now experiencing global headaches that were increasing over several days. She had leg weakness and incontinence, and we thought, well, maybe this is tethered cord. And then she had a personality change and memory loss. And so that made us think of the superior sagittal sinus, and indeed we performed a venogram and found, again, a thrombosis in the sinus, and we treated that with Lovenox, and she was out of the hospital a week later. This 25-year-old girl with severe retroorbital pain behind the eyes, and global headaches, also had dystonic seizures. Then she developed a loss of consciousness, and we thought we were losing her. The MRB showed a total thrombosis of the left transverse sinus seen here. We treated her with Lovenox, and she literally walked out of the hospital, walked out of the intensive care unit 2 days later. So Dr. Liu down at the University of Virginia, he's now moving up to Hershey in Pennsylvania, is one of the leaders in this field, and I asked him what he felt were the characteristic signatures of thrombosis in the brain. He said moderate to severe headache. The patients complain that, quote, my eyeballs feel like they're popping out. There's a pressure in the head pushing outward. The pain may be present upon awakening, sometimes decreases with standing up, but it can also worsen as the day progresses. If there's a thrombosis in the superior sagittal sinus, that's the sinus over the top of the head, there are usually stroke-like changes, cognitive changes, and it's more serious. A lot of patients also have pulse synchronous tinnitus, meaning there's a pulsatile ringing in the ears with every heartbeat. Now, thrombosis can occur in the jugular veins as well. On the left, you see a normal jugular vein draining the blood out of the brain. And on the right, you can see the jugular is pinched by the transverse process of the first cervical vertebrae and other structures. Now, we're finding out in the last few years that all of the blood does not drain out of the brain through the jugulars. In fact, when you're standing up, a lot of the venous drainage occurs around the spine, the perivertebral venous plexus. And when you lie down, most of the venous drainage is through the jugular veins. Now, if you look at a standard CT angiogram, a CT with contrast, on normal people, a quarter to a third of them will have some degree of jugular venous compression. So it's not that easy to make the diagnosis. The compression is usually by the posterior belly of the digastric or the stylohyoid ligament, often over the transverse process of C1. But about 1 in 5 patients have a severe stenosis, and half of those have collaterals around the base of the skull, around the condylar veins, as shown here. Now, just last week I saw a lady who was complaining of continued headache and brain fog, and I think we had ruled out issues in the brain itself and the cervical spine. So I did a lumbar puncture, pressure was moderately elevated, her vision got better, but the headache continued. We obtained this MRV, and it shows that the blood is draining through the transverse sinuses, but then instead of draining down the jugular veins, it's going through all of these other facial and perivertebral veins. She had a bilateral jugular venous thrombosis or occlusion. And that's one way that the jugular vein is treated, with a stent, and Dr. Liu performed that procedure. Now, this 57-year-old man had a sudden pain in his left eye and double vision, and then the following day, weakness on that side of the face. He had normal retina, normal fundal exam, but he had weakness of the left eye muscles, a drooping left eyelid, a sluggish pupillary reflex, and very high intraocular pressures. And this is typical of a carotid-cavernous malformation occurring in an EDS vascular type patient. So typically there'll be a bulging of the eye, weakness of the muscles, and an afferent pupillary defect with very high intraocular pressures. So this gentleman presented with the new onset of suboccipital pain on one side and decreased vision. So we performed the CT angiogram, and you can see that the vertebral artery is not flowing at the C2 level on the right side. Remember, the radiologists do everything backwards, so that when I say right, it will look on the left to you on the film. So the arrow shows a no flow through the vertebral artery, and on these axial views, which are slices through the spine, you'll see no flow on that side. So this is characteristic of a vertebral artery dissection with suboccipital headache on the side of the dissection, altered vision, dysarthria, which is difficulty speaking, impaired coordination, stroke-like symptoms, and it usually occurs after blunt trauma, manipulation, even massage, and more often than not in the hypermobility connective tissue population. Now, with its counterpart dissection of the carotid artery, these two arteries account for 1/5 of non-hemorrhagic strokes. And the pathophysiology of what's happening is the blood is breaking through the inner lining of the artery and going into the wall of the artery and occluding the flow through the artery. That's a dissection. The blood dissects into the wall of the artery. So here's a normal vertebral artery on the left, and on the right you can see kinking of the vertebral artery, and this person had just very vague symptoms of TIA-like symptoms. This young lady from Canada had her entire left cerebral blood flow coming from the right side through an unusual branch from the internal carotid artery, and she had TIA-like symptoms. And there's that unusual branch coming from the right side to feed the left. This 35-year-old woman with Ehlers-Danlos hypermobile type had a 20-year history of severe bifrontal headaches and emesis. And it just happened that the week before she went to Hopkins and had a full vascular exam and was given an AOK. But on this morning, she came into the emergency room. She'd been massaging her sternocleidomastoid muscles vigorously the night before and now had this extreme headache. It was like an aneurysm. So we got a CT scan, which was normal. And so I did a CT angiogram, and we found a dissection of the left carotid artery. So there's no flow coming up the left carotid. She should have had a stroke. But then it turned out she also had a dissection on the right side, and she should have not survived. But she did with almost zero neurologic deficit. Now, if you have a carotid dissection, typically there's pain over the temple, over the side of the head. There's often a loss of vision or decreased vision on that side. There may be a small pupil meiosis as part of a syndrome called Horner syndrome, which is ptosis, meiosis, and hydrosis. Now, we're back to a Chiari again. It's very easy to assume too little looking at this Chiari, say, well, right, I'm going to decompress that and the headaches will go away. But ligamentous laxity confounds a number of these cases. The literature shows that there's a failure rate of decompression for Chiaris that ranges from 20 to 50%, depending what series you look at. Now, on the right there, you see the decompression of the Chiari. That itself may not take away the headache. And George Kleekamp looked at 45 revision decompressions and found that over 20% needed a reduction, fusion, stabilization for signs of instability or basilar invagination. So he stressed the importance of dynamic studies to look for instability and to do a fusion if necessary. And Millerat and Paola Bolognese and Claire Francomano and others showed in a very large series that at least 13% of Chiari patients have a connective tissue disorder. I think that that rate is much higher, at least in the patients I've seen. But keep in mind, if you have EDS, you can have Chiari symptoms without having the Chiari. Dr. Castori has done a great deal of work with EDS, and we're very indebted to him. And he's made documented the severity of headaches of EDS patients. And Jack Home has noted that the hypothesis that Chiari malformation as a consequence of occipito-atlantoaxial instability may be more common in symptomatic EDS patients is supported by the reports of EDS cases with headache and the Chiari malformation. So it's not hard to understand why hypermobility should cause headaches when we recognize that the stabilizing structures between the cranium and the spine are ligamentous primarily. There are muscles shown there in red, but the major stabilizing structures are ligamentous. It's the condylar ligaments, the tectorial membranes. Goel has done a great deal of work in India, and he asked the question, why does ligamentous instability give rise to basilar invagination? And he says that instability gives rise to microtrauma, and this causes a kind of resonating pathophysiological process where the trauma causes more neurological injury, less control over the head, less neuromuscular control, and then increasing instability. And this is exacerbated by malnutrition, vitamin deficiencies, and deconditioning, which is what we see in Ehlers-Danlos syndrome. Now, Dr. Graham and others noted for the last 20 or 30 years that headaches and quadriparesis and clumsiness suggested that something was going on, not in the joints, but in the central nervous system. And Van de Pape, who is Francisca Malfate's mentor, showed in this patient with EDS the basilar invagination, the compression of the brainstem by the odontoid. And I think you can see that significant compression right there. That's basilar invagination. Now, Doug Brockmeyer out in Utah showed in his series, retrospective series of over 100 patients, that more than, or that 20% needed an occipital cervical fusion, usually for basilar invagination or a kyphotic clivoaxial angle. So, when does ligamentous laxity at the craniocervical junction become pathological? Probably every EDS patient has some degree of hypermobility at the craniocervical junction. But when does it become pathological? So on the lower left, that's a patient with rheumatoid arthritis, and the odontoid is sticking up into the brainstem. That's clearly pathological. And the second and third cases, you can see a retroflexed odontoid compressing the brainstem. But we had a meeting in San Francisco in 2013, and representatives from 17 institutions agreed that there were 3 useful metrics, radiological metrics, that would guide us to the formulation of whether that patient had instability or basilar invagination. We'll go through them. First is the clivoaxial angle, and that's the angle between the base of the skull and the back of the second cervical vertebrae. On the left, that's normal, about 150 degrees. On the right, that's clearly pathological. That angle is actually 120 degrees. And anything less than 135 is probably abnormal. The kyphosis of this angle between the base of the skull and the spine is what causes a kink in the brainstem. And if you kink the brainstem, it doesn't work properly. And keep in mind that the brainstem is wired into every part of the cortex. So nothing happens on the surface of the brain that does not relay through the brainstem, and actually the cerebellum for that matter. The Grab-Oaks measurement published in 1999 in Alabama looks at this line drawn between the skull base, the basion, and the lower end of the C2 vertebrae. So here's the basion, and here's the back of the C2 vertebrae. And the measurement from that line out to the dura should be normally about 5 or 6 millimeters. If it's 9 millimeters or more, then there's a high risk for ventral brainstem compression. And on the right there, you'll see more than 9 millimeters, and that represents ventral brainstem compression. Harris looked at 400 subjects, and he found that the distance from the basion, the base of the skull, to the top of the odontoid was always less than 12 millimeters, and said if you had that distance, 12 millimeters or more, you had craniocervical instability. Furthermore, that measurement should not change from flexion to extension. It should remain constant. So here's a normal. The person's bending forward, and the basion is lying right above the middle of the odontoid. And on extension, it's still there. That's normal. But here's an abnormal case. Look at that odontoid, and the posterior axial line is 15 millimeters away from the skull base. That's clearly very abnormal. Here's another abnormal case. Inflection on the left. You see the base of the odontoid is about 7 millimeters from the posterior axial line. And on the right, the skull slides back. So it's translating. And there's abundant literature that shows if the translation is more than 1 or 2 millimeters, then you have craniocervical instability. Now, if you don't have dynamic imaging, you might miss this. On the left, that's a normal supine view, the patient lying on his back. And you can see, well, there's a little bit of basal invagination, but it doesn't look too bad. The brainstem's pretty straight. But on the right, you can see that the skull has shifted forward and is now more ventral brainstem compression. So how does a patient with craniocervical instability present in terms of headache? The headache is in the suboccipital region. 70% also have neck pain. Pain can sometimes radiate to all parts of the cranium, and it's described as shooting, throbbing, stabbing, sharp. And it's worse with bending, exertion, and looking up. So what's the effect of treating this with a reduction? A reduction is simply reducing the deformity, and a fusion with bone, usually allograft from the bone bank, and stabilization with screws into the bones. That's a fusion stabilization. Well, we looked at this at 1 year, and now we're looking at 5-year data. But conservatively, before surgery, these patients had an average pain of 8.2 and it dropped to 4.5 on average. Notice the pain there's still pain there, and that's because most of these patients have several types of headache. They may have TMJ pain, they have a migraine. So the pain does not go away with the craniocervical fusion, but it does improve. And similarly with neck pain. Now, I've been discussing guidelines, like the pirate said. They're guidelines, not rules. And so this lady clearly has a Chiari malformation and has even a stretching of the brainstem and a kyphotic clivoaxial angle. But her headache was quite tolerable, her neurologic deficits were minimal, and she's still working. So I advised her not to have surgery, and we'll just follow her year to year. Here's a young man who played the French horn. And you can see on the left the Chiari, the cerebellum pushing through the foramen magnum. And there's something unusual about the bones there. On the CT scan, if you look on the right, you see that the first cervical vertebrae is fused to the skull base. So this turned out to be a Hox D3 homeotic transformation. And I know all of you all were thinking that when I showed you that picture. And so I performed a decompression on him with the idea that he will probably need a stabilization in the future. But this is his case at 1 year, and he has great CSF flow, and he seems to have maintained his stability between C1 and C2 and not needed any further surgery. Now, many people assume that headaches originate as well as reside in the head. But Dr. Long, the former chairman at Johns Hopkins, has emphasized that a lot of these headaches begin in the neck. So he quotes, to quote him, he says, "We all understand sleep disturbances, visual disturbances, dysautonomia associated with Chiari, but headaches less well understood. And at least 25% of patients after Chiari malformation surgery continue to have the headache. And this headache, he states, is clearly related to upper cervical instability. I simply want to re-emphasize that mechanical instability is well known to occur as part of the normal pain process." So he looks back to Kirkley Willis, who was the first one to describe headaches as a result of spinal instability in 1946. And his student, Harry Farfan, described micro-instability as causing pain. And then Bokduk described ligamentous laxity as a cause of headache. And Long has, again, made the point that acute strains and sprains of ligaments, which are impossible to diagnose on any imaging we have, can cause headaches. So cervicogenic headache, that's a headache that arises in the cervical spine, is one of the lesser causes of headache in the general population, but has the highest quality of life burden. 2/3 of the population of headaches, of which half misdiagnosed. Tension headaches have a prevalence of 38%, migraine prevalence 10%, chronic daily headache 3%, and cervicogenic headaches typically about 3% of the total in the normal population. But cervicogenic headaches can also arise as a neuromuscular phenomenon. Typically, any structure innervated, these manuscripts said in the upper 3 cervical vertebrae are a potential source of headache. But I can tell you that persons with spinal instability all the way down to C6, 7, or even C7, T1 can have headaches. The headache just travels right up the spine. And at C6, 7, it can interfere with the vertebral artery, which enters that level, and stimulation of the vertebral artery can cause a severe suboccipital headache. Muscle tightness involves at least 1 out of 3 cervicogenic headaches, and typically involves the trapezius, sternocleidomastoid, scalene, levator scapulae, pectoralis, and major and minor short occipital extensors. And Dr. Mitakaitis has talked a lot about this, the importance of those muscles in headache, and how temporomandibular joint syndrome can actually trigger those muscles into spasm and cause headaches and sleep apnea and even weakness of the abductors of the arms. Now, C1-2 instability is really difficult to diagnose. It's been diagnosed it was found to be very common in the EDS vascular population. Now, the mean rotation of the C1 upon C2 is about 35 degrees. And it's held in check by certain ligaments called the alar ligaments that go between the skull and the odontoid process. Now, if the alar ligament is compromised, this allows increased turning to the opposite side. So the distinguished Canadian neurosurgeon Harold Hoffman said that overstretching or rupture of the alar ligaments can result in rotary hypermobility or instability. So when I make this diagnosis, I look for headache and neck pain, syncope, blacking out or presyncope, nausea, tenderness over C1, spasticity, hyperreflexia, sensory deficit to pinprick, which some of you have experienced, the pinprick, and excessive rotation of C1 upon C2. Now, to look for this, I put the patient supine on the CAT scanner, and then they rotate their head fully to the left, 90 degrees if possible, and then fully to the right. And then the scan is from the skull base down to C3. And if the measured angle in the top middle between the first and second vertebrae is more than about 41 degrees, then they're in the range for C1-2 instability. And you can see lower left how with instability, the facet overlap, those facets should be overlapping, but they're sliding off one another. And if you just tilted this girl a little bit more in that direction, she might dislocate that neck. At a 45-degree angulation between C1 and C2, the blood flow through the vertebral arteries ceases. And that's the blood flow to the brainstem and the back of the brain, the visual centers. Now, we have a number of other ways to look at C1, C2 instability, but it's still very difficult. Professor Smith in Great Britain has done excellent work in conjunction with Dr. Graham. And on the upper left here, you can see in black, that black band, that's the transverse ligament that holds the odontoid in place. And on the right, that transverse ligament is very sketchy, that black line, and that person has instability. And if you look upper left, above that white area is a black band. That's the alar ligament. And looking down lower left, you can see thinness of that ligament, and that's a unstable alar ligament. Now here's a patient who had an eccentric odontoid within the C1 ring, and you see it's tilting over there, and that's probably got an alar ligament incompetence. This patient had a transverse ligament incompetence, shown here on the left, and on the middle picture, middle MRI, you can see that the cord is being squashed between the odontoid and the posterior ring of C1. Now, Gohl has described a fairly normal-looking appearance on MRIs, but intraoperatively, the C1 and C2 can be unstable. It turns out, looking at the pictures that he showed in his manuscript, that this patient, shown with the arrow, actually had a HOXD3 homeotic transformation where the C1 ring was fused to the skull base, which puts a lot of stress between C1 and C2, and that's why that patient was unstable. And Yin Yu and Zhu from China reported on other patients where the C1 slides posteriorly off C2. Here's an incomplete C1 ring that can increase the instability of C1. And this is how we fix it. We place a bone graft between the ring of C1 and C2, shown up here. That's the sagittal view from the side. And upper right, you see the view from the back, and then the 3D reconstructions down below. And you might make out the hardware, the screws on the side, and the bone graft in between. Now this is a Kimberley anomaly. It's that circle of bone above C1 due to the calcification of the fibrous ligament of the condyle, and it entraps the vertebral artery. This is common, but sometimes it may cause deafness or dizziness or drop attacks or paresthesias or even dissection of the vertebral artery. It's very important to get dynamic films of the cervical spine if you suspect a problem there. So this young lady had a relatively normal supine MRI on the left, but when we placed her on extension on the right, you can see that there's spinal cord compression. This was discussst by Dr. Benzel, who's chairman at Cleveland Clinic with Shadid, who pointed out that with a kyphosis shown there on the right, that there is a bending of the spinal cord, and this can cause a sagittal bowstring-like tethering and a myelopathy. So you can see that the spinal cord on the left is actually stretched on the right. It's the same patient. And that stretching of the cord causes myelopathy or injury to the spinal cord. So Punjabi and White looked at all the criteria by which one would predict instability, and a positive stretch sign such as flexing the neck, angulation on flexion and extension of more than 20 degrees, or an angulation on one film of 11 degrees or more, a subluxation of more than 3.5 millimeters, the presence of spinal cord injury, stenosis, radiculopathy, and so on. So this lady had a headache, suboccipital pain, pain over the shoulders, between the shoulder blades. We couldn't work out what the problem was. She had myelopathy, severe pain, and we obtained a flexion extension view, and on that extension view shown there, you can see a subluxation of the spine, compression of the spinal cord, and we fixed that with a simple anterior cervical discectomy, fusion, and plating, and she left in 2 days. So it may become difficult to differentiate between migraine and cervicogenic headache. Classically, in the non-EDS population, migraines occur in the younger female population. They're in the front of the head, more often unilateral with nausea, phonophobia, so noises sound too loud, photophobia, they're too sensitive to light, pain bending forward, relief with migraine meds, throbbing, versus cervicogenic headache, more common in the males, posterior head, more often unilateral, without nausea and photophobia. Pain is increased with neck posture and without the throbbing. Unfortunately, in the EDS population, there's a lot of blurring of this distinction. The headache may arise from injury to the nerve fibers. So you can cut a nerve fiber and then you'll get a neurological deficit, and that's very easy to diagnose. But if the peripheral nerve gets stretched or sensitized, it becomes very difficult to diagnose. So you can have a peripheral sensitization, or you can get sensitization in the brain, and then you get paresthesias, which are annoying numbness in the hands and body, allodynia, which is a pain that seems to have no reference to the where you're causing a stimulus, dysesthesia, which is just a painful sensation, hyperalgesia, which is hypersensitivity. And so these kinds of sensitization phenomenon are more difficult to diagnose through a standard neurological exam. And characteristic of that are the greater occipital nerve, lesser and third occipital nerves, which can cause very painful neuralgias. So the posterior branch of the occipital nerve comes off the C2 nerve root, can be very painful, and that arises from the C2 dorsal ramus as a small contribution from the third cervical vertebrae. This is an ultrasound. That nerve rises up through the semispinalis capitis, the splenius, and the trapezius muscles, and then comes to lie about 1.5 to 2 centimeters off the midline at the back of the head. And you can test these with a nerve block, but they can cause very severe pain. I'm going to just go forward a little bit. Now, migraine headaches can also be triggered by a hole in the heart. This young lady was having TIA-like symptoms and migrainous-type headaches. And we did a ultrasound with a bubble technique. We saw bubbles going from the right heart to the left heart. We knew there was a hole between the atria, and she underwent a procedure to correct that, and the TIA-like symptoms and headaches improved. There are remote causes of headaches. So tumors can cause released proteins in the spinal fluid, causing hydrocephalus. And tumors can also put traction on the spinal cord, causing a tethering effect that can cause headaches. I had one lady shown there on the right with this huge ependymoma and terrible headaches. When I took out the ependymoma, her headaches went away. And that's an occult, just like occult tethered cord syndrome. If the spinal cord is tethered by a tight phylum, that's the little fibrous band that holds the spinal cord down to the base of the spine, that can cause headaches. So we found that about half of our patients with tethered cord have headaches, and it feels like something pulling on the back of the head. And it's worse when they flex their neck downward. TMJ dysfunction is a really common cause of headaches and neck pain. And this is a major, major issue with Ehlers-Danlos syndrome. So this is a very highly sensitized structure on the side of the face right here. And I was sitting next to one of the world champion boxers on the flight up, and he was talking about the knockout punch hitting the jaw, and I suggested that instead hit back over the TMJ, but make sure you don't kill them. Anyway, he's going to get back to me. I'm going to read his MRI for free. It's highly innervated, and it relates to a lot of the muscles in the neck. It can cause dysphagia, sleep apnea, weakness, and headaches, severe headaches that wake you up in the middle of the night. So I encourage you to see people of caliber like Dr. Medakaitis, who's one of the best in North America, and there's some others like Joe Tregaskis in Richmond. It typically refers pain to the suboccipital region, can refer pain into the levator scapulae and cause pain under the shoulder blade, pain over the temporalis muscle, and pain above the eyes. And it's worsened with chewing, talking, and wearing a neck brace. So a lot of patients who have craniocervical surgery can wear a brace. The brace will cause more TMJ pain, and then it becomes a real problem. The disorders of immunity, and Ann Maitland has given a brilliant discussion of those, so I won't reiterate. Mast cell activation syndrome, which is exceedingly important. We have cases with PANDAS, which is pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections. And they cause headaches and movement disorders and compulsive behavior. And there are other forms of antibodies to the various neural receptors in the brain and the spinal cord that can cause a brain on fire and all kinds of neurologic deterioration, such as the anti-N-methyl-D-aspartate receptor encephalitis, which is characteristic of the whole group of paraneoplastic limbic encephalitis. So it's really important then to make a precise diagnosis, and one of the important things here is a dynamic flexion extension MRI of the cervical spine, sometimes of the thoracic and lumbar spine, and all of the other tools that we use. So in conclusion, though a useful measure of disability and suffering, headaches are highly variable and nonspecific. A precise diagnosis must be predicated upon a substrate of demonstrable neurological and radiological findings. And awareness of the many comorbid conditions of Chiari malformation is important to establish the origin of the headache. And ligamentous laxity seems to be an important feature in many of the conditions that generate the headaches. So awareness of the diagnostic features of hereditary collagen disorders assists in the recognition of these, and I don't need to tell this group that. I'd like to acknowledge my co-workers, Claire Francomano, Miles Kobe, Peter Rowe, Rodney Graham, Alan Pasinke, Petra Klinge, Ed Banzel, Mark Luciano, Mark Alexander, Jonah Murdoch, Jessica Adcock, Rebecca Tuckman, Joanne Wang, and Michael Healy in preparing this talk, and also Joe Dragaskis. So thank you for your attention.